Hi, my name is Dr. Elisa Minkin. I'm a general pediatrician and I'm also chair of the Jewish Orthodox Women's Medical Association Preventative Health Podcast. And I'm really excited to be here today with Devorah Levinson. Hi, Devorah.
Hi there.
Hi. Devorah is a referral specialist and the director of Eating Disorders Division at Relief Resources, a free mental health referral service that caters to the needs of the Orthodox Jewish community. She has a strong background in communal work in both the United States and abroad. Her role at Relief is to provide mental health referrals and information to families and patients, and she serves as a conduit to appropriate and effective care. Her work consists of researching new clinicians, facilities, and treatment options, as well as promoting cultural sensitivity to clinicians who have little or no experience with Orthodox Jewish patients. She has presented on the topics of mental health and eating disorders in the Jewish community at schools and hospitals in the tri state area. She has also been involved with the National Eating Disorder Association and has a strong focus in eating disorder prevention, which is what I want to focus on today. Thank you so much for joining me, Devorah.
Thank you so much for having me.
So let's start with just explaining to our listeners, they may not have heard of Relief. I actually refer to Relief at a lot of my podcasts when I want to give a resource. It's my number one resource, but not everybody knows. So can you please start with what is Relief and what do you do there?
Okay, sure. So Relief was founded about, I think, 16, 17 years ago now. There was definitely a very strong need, as there is in any community, for mental health resources, and they just felt that there were people weren't that didn't know where to turn, didn't know where to go. So in many ways, we set out to be a little bit like the Consumer Reports of mental health.
Mhm.
Who do you call when you need to know who's a good therapist, who's a good psychiatrist? You may ask your next door neighbor for a good pediatrician, but you're not necessarily going to ask them for a mental health professional. So what started out, 16, 17 years ago, and people had even said, no one's going to call, or else you'll just be like a small organization in one corner of Borough Park, has just exploded over this time. And we have offices in Israel, in the UK. We have two different offices in Canada, in Toronto and Montreal. And in the United States, we have in LA and in Baltimore, and then New York, New Jersey, and even upstate in Monroe. So we do mental health referrals, exactly like what you had said. Any mental health recommendations, treatment options, information, education as well, sometimes on anything from little kids who are having behavioral issues to geriatric patients, and everything in between.
And how do you find out who are good people to refer to?
So it takes a lot of time. It takes a lot of time and a lot of effort. We do a tremendous amount of research. We try and always looking for good names. Whenever we speak to someone who, let's say, they'll call up and they'll say, "I need a psychiatrist," and we say, "Who's your therapist?" And they say, "Oh, I have a fantastic therapist."
Mm.
That's in many ways where things start from. But from there, it goes to finding out their qualifications, getting their resume. And most of the people we have that we refer to, we've actually met in person.
Wow.
I'm really bad with the numbers now, and it used to be like of the 3,000 names we had, we've met about 1,700. I know it's even higher now. So we try and meet these clinicians as well. We have periodic meetings with new therapists and new psychiatrists, new doctors, where we get a feel for them clinically, but we also get a feel for them as a person. Who's going to fit with them, who's going to be a good match. With in the medical profession, it's really nice if you like your doctor, but bottom line is, do they know what you need to keep you alive and healthy?
Right.
While in the mental health field, the therapeutic relationship has a lot more to do with the success of the treatment. So we really try and see, okay, who's going to be a good fit for this one? Who's going to be a good fit for that one? And we've really learned a lot over the years as well. We are not mental health professionals, and that's by design, not by default. My job is not to fix your problem, it's to send you to the right people who
Mhm.
can. But with that being said, we really do spend a tremendous amount of time with our own knowledge. We used to go to grand rounds, before COVID, in Columbia and Cornell. We really have a lot of great clinicians out there, the top of their field, who just really are just wonderful to us as an organization, and we can tap into, and we can call, and we can reach out to, we can ask them questions. What would you do for such a case? What do you know about this? And we really have had the opportunity to just learn so much. So, you know, with all of that together, I feel very confident in our recommendations. And we also do follow up wherever we can. You know, sometimes when it gets really busy, unfortunately, that you know, the follow-ups don't happen as often as we would like, but we really try to follow up with all of our callers and find out, you know, what was your experience? How did it go? And we base those referrals on feedback.
It is
So
great.
that's, you know, really what we do.
How do people reach relief? I just want to make sure at the end I want to give it again, but I want to make sure sometimes my end gets cut off. So
Right. So, so we have, first of all, you can reach us online at our website, www.reliefhelp.org. That's help as an H-E-L-P. And you can start the process right there. You can schedule an appointment time with any of our referral staff to make a phone call so that you know when we'll be reaching out to you to make that easier. We're not playing phone tag. Or you can just dial the main number. That's the 718-431-9501. And that leads you to everybody. So, you know, if you, you know, need something out of state or in a different country, it's got all the resources listed there. So that main number is really the best number to call. And we've got a great secretary. Just, you know, press 0 and you could reach her or leave her a message. It does get busy. That's the one thing that is hard, and definitely now post, I don't want to say post-COVID, mid-COVID, you know what I'm saying? Like, I don't know where we're up to with COVID, but, you know, there's definitely been waves as far as the need from the community, and we're really riding high right now. So it is taking us, unfortunately, longer. We are a nonprofit. We are a free organization. We don't charge for anything. And as are all nonprofits that are free, we're short-staffed. So unfortunately, it can take us a little bit longer to get back to people more than I would like.
Right. So what would people expect?
As far as like a turnaround time, or as far as what to expect when you call?
From the time that they call till they get a call back, because you're going to put a call, you're going to leave a message. You're not immediately going to speak to someone.
Right.
Correct?
So that's why the phone appointment system is really the best system. And that's what we've really been trying to fine tune. The phone appointment system, you know, you can do it again online or through the secretary. You know exactly when we're going to be calling. Right now for adults, because we have two main divisions. We have the adults, or for anyone age 15 and older, and the kids division we do up until the age of 14. That's just sort of how we separated it. For the kids division, I think they're booking maybe 4 or 5 days in advance right now, again, because these things are times are really busy. For the adults, you know, it could be a week. It could be a week.
Right. So this is not a warm line or a hotline. People should understand they can't call up and get help immediately.
Exactly. Like I said, my job is not to fix your problem. It's to send you to the right people. If we do have an emergency, meaning if you call up and you listen to our voicemail, it says, if this is urgent and may require hospitalization, please press 9. So sometimes, let's say there's a psychiatric emergency and somebody's got to go to the hospital. They just want to know, which hospital do I go to? You know, is it, you know, can you at least give me guidance on where to go? Or this is an emergency now. Do you have a psychiatrist that has emergency availability? So sometimes for those truly urgent situations, we can, you know, sort of help them out with that. Or I've had, you know, because of my work with eating disorders, I have had situations where, look, you know, somebody fainted, or this is, you know, we have Hatzalah here now. Where are we supposed to go? And we do try and help with that wherever we can, but we never want anyone waiting for us.
Right.
No one should ever wait around for us. You know, if you don't get a response, you don't get a call. You know, no one should ever say, well, I didn't do anything because I was waiting to hear from relief. Meaning, as far as if it's like a crisis, like if it is an eating disorder and you know, someone's waiting to see a pediatrician, let's say, or someone's manic, you know, this is a psychiatric issue. Like, don't wait. You can page that emergency number, and definitely we would do our best to call you back, but it is not a crisis line. No.
Right. And it's like when you call your doctor's office and they say, if this is an emergency, hang up, call 911,
Right.
go to your nearest emergency room. This is not what relief is for.
Right. So look, you know, again, we try. We definitely will. We definitely will try. But if, you know, with that page, and if you're not getting that answer, then you've got to go forward, just like anything, you know.
Right. And I think most emergency rooms are prepared for mental health emergencies as well. I mean, they all should be.
Right. Look, bottom line is someone has to be safe. You know, we want the experience to be as positive as possible. Look, having to be hospitalized for psychiatric emergency is not going to be fun.
Right.
Regardless of where you go, it will not be fun. Okay. We want it to be as positive as possible. We want to reduce the amount of stress. We want you to be in a place where you feel confident with where you're going. So if we can help you with all that, and you can get through to us, then, you know, and we can help you with that, then by all means. But if you can't get through to someone, then as long as the person is safe, you know, even if you go to a hospital that's not our first choice, if someone's suicidal, God forbid, they've got to be in the hospital.
Right.
You know, that's the thing.
Right, it's the priority. So
Hmm.
let's move on to eating disorders because this is your
Yes.
specialty. And
Yes.
I'm going to just let you start with giving us a background because there is a wide range of eating disorders.
Yes, yes, there is. So first of all, like I had said, we have the two main divisions in my office. So I also do referrals for ages 15 and up.
Hmm.
But in addition, they brought me on, now it's like 13 years I'm here. They brought me on specifically to do the referrals for eating disorders because eating disorders are so complex. They wanted one person to really, try and be as knowledgeable as possible in the illnesses and as knowledgeable as possible in the different treatment options. So that's what I do in addition to the regular referrals. So when it comes to eating disorders, there are a few main types is what we really deal with. So anorexia is the one that's going to, of course, get the most attention. That's the
Hmm.
one where someone is restricting and they're eating. They're not able to maintain a healthy weight. They have a fear of fat. They have a fear of gaining weight. There's a lot of obsessiveness. It's all eating disorders, as far as specifically anorexia, are egocentric as well. So what is egocentric? It means it really takes over the person's thinking. If I could have, let's say, OCD, and part of the diagnostic criteria for having OCD is that I recognize it doesn't make sense. I may not be able to fix it on my own,
Hmm.
but I know it doesn't make sense for me to wash my hands so many times a day. When it comes to eating disorders, however, and this is where people really get stuck, this denial that they see is really coming from the egocentric nature. The more malnourished someone becomes, the less clearly they think. So you'll have these kids who will be kids or young adults or even adults, who are really, in many ways fighting getting treatment because,
Hmm.
it's I'm just being healthy, or it's really not so bad, or I could do this on my own. So anorexia oftentimes gets more attention, and also because of the amenorrhea, because these girls and women will lose their periods as part of the malnutrition. When the body um, isn't getting enough nourishment, it
Hmm.
starts to shut down. So one of the first things that go are the periods. So that's often, in the community, that's one of the big warning signs and one of the big pushes that parents and families will have, where they will reach out for help. Um, so I would say thank God for periods, because that way people take care of eating disorders. So anorexia is the number one,
I'm going to interrupt you
and
just
it
a
is.
second. Boys can get anorexia too, though.
Yes, 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 yes,
Hmm.
100%. Thank you very much for adding that in.
Hmm.
It's trickier. I think boys and eating disorders in general, I find in the
Hmm.
community, based on my data and my numbers, boys have eating disorders pretty much the same rate as they have in the broader community, which is a very small number, much
Hmm.
smaller number, generally speaking. But I find it's a very different animal. So yes, because they don't lose their periods, so again, there isn't going to be that big warning sign that parents are going to see. A lot of boys who are getting eating disorders, if they're getting them in high school, they're not home. Many of the boys in the Orthodox community, they're away at school, they're away in yeshiva. So the parents aren't noticing as much, or even if they're home, but they get home so late at night, and parents don't think about it as much.
Right.
The boys that I'm seeing with eating disorders, and again, I'm glad that you mentioned that, many times it's coming from a place of scrupulosity, that there's like
Mm.
an OCD component. They'll have, I'll have boys, let's say, who are very, very religious, who are a little more obsessive, more rigid, and they stopped eating or they reduced their intake because, let's say, it affected them going to the bathroom. And they were afraid, if I have to use the bathroom, then I can't pray, then I can't
Wow.
learn. So that started oftentimes being an issue. Or they cut out sugar and fat, and sweets, because to an extreme, because they wanted to be more spiritual. They didn't want to give in to their taivas. They didn't want to give in to their desires. So that often is the case. I can get boys with the next type of eating disorder, which I'm about to describe, with bulimia. But that's even bulimia in general is, a lot of people can keep that hidden for a long time.
Hmm.
So all the more so boys who are bulimic, it's even harder.
Right. They can
Um,
hide it because their weight is often normal.
Exactly. So
Hmm.
bulimia would be the next eating disorder that we're describing, and that's when someone can have a weight it can be even overweight, and bulimic, but oftentimes it's normal, maybe a little bit less than normal sometimes, where they'll eat large amounts of food and then they'll purge afterwards. They'll vomit it up afterwards. There's sometimes that they'll eat small amounts of food even, but they'll vomit it afterwards. And bulimia is just as life-threatening as anorexia. and which a lot of people don't realize because they think, well, her weight is fine. When someone is constantly purging, it can cause a lot of medical complications, and in addition, it can affect the balance of potassium and electrolytes in the body. I had someone once who actually had a heart attack, a young woman in her 30s who had a heart attack. And there was also a male patient, the same thing. So it is a very serious illness just the same. So a lot of patients with bulimia, there's a lot of shame involved. And you may not have that cognitive impairment as much as the anorexics who are malnourished, but oftentimes there's co-occurring issues. There's depression. There can be, like I said, a lot of shame. There can possibly be a self-harming as well. So bulimia carries its own set of challenges there. So those are really the two big ones. After those two illnesses, there is also binge eating disorder. So we will get calls from binge eating patients with binge eating disorder sometimes. The binge eaters, I always feel bad because I feel like they're a little bit the neglected eating disorder. People are much less likely to recognize that their eating habits are something that they need therapy for. They would much rather just say, oh, I just don't have self-control. I need to go on another diet. Let me try another diet. Let me try another diet. Or I'm just terrible. A lot of self-loathing again, before they actually say, you know what, this is a real problem and I need a therapist. So binge eaters are the ones who are not purging and are not restricting, but they will eat excessive amounts of food in a very short amount of time. And I'm not just talking about like, oh, when someone goes to a kiddush, they say, oh, I binged, I had 2 pieces of cake. I'm talking about being alone at night and eating the entire cake, the whole bag of chips and half a bucket of ice cream. A very large amount of food in a short amount of time where they almost feel like they're just not even aware of what's going on. So the binge eaters are actually quite successful in treatment once they do reach out, and it responds very well. But I find they're less likely to recognize it, and they're just more likely to say, I just need to try another diet. So the binge eating would be the third type there. And what's important to know, go ahead.
I was going to say, what is the treatment for binge eating that's so successful?
So there is actually, I'm not sitting in my office right now, so I don't have the book in front of me. There is specific cognitive behavioral therapy for binge eating that really works very well. Binge eating is also one of the few illnesses that has guided self-help that can also be very, very helpful. There's a psychologist and author by the name of Chris Fairburn, who actually wrote a book that works very, very well on binge eating. It's the type of thing that if you're going to do it on your own, if it's going to work, it will work in 4 weeks. If it's not going to work in 4 weeks, it's not going to work. It's even more effective when you do it together with a therapist. But each situation, again, that's why we have the eating disorder division. Each situation is unique. So I'm not giving any blanket recommendations, but it is in general, though, binge eating, I think on multiple levels, because it doesn't have the malnutrition component to it. It doesn't have that cognitive impairment. It doesn't usually come with some of the other mental health complications that bulimia will come with. So I think it does respond. It does respond well.
But before you start on, that's another point that I want to make sure we spend a little time on. When you talk about cognitive impairment, I want to just spend a little time explaining what you mean by that. What is happening?
What I mean is that, I explain to parents, and you're the medical professional, so please, add and subtract to anything I'm saying or correct.
No, you're doing great.
But what I explain to parents is if you don't eat breakfast and you don't eat lunch, I always say, how patient are you going to be with the kids by supper time? So what happens is the less nutrition the body starts to get. I mean, I think I know there was a study, I forgot what it was called, years ago, where they actually, they would never be allowed to do this now, but they actually withheld food. They had volunteers and they starved them, and they recorded what their responses were. And what ended up happening is that they, I think by default, they became depressed. So depression is definitely, a default of malnutrition. They became much more obsessive and rigid. I've had parents calling about their teenagers, and they said, "Oh, it's OCD." And then once we started asking more questions about what's going on, and we saw that it was only regarding food, and it only started after she lost the weight. it didn't predate her weight loss, that once she got treatment for her eating disorder and she gained the weight, the OCD-like behaviors disappeared.
Wow.
So with the malnutrition, you get depression, you get rigidity, you get obsessiveness.
But even
And that's, again, that's cognitive impairment. I mean, the treatment for adolescents, and I know now we're skipping ahead, but
mhm,
the treatment for adolescents with eating disorders is something that's called FBT.
mhm,
FBT stands for family-based therapy. It has the highest rate of recovery and the lowest rate of relapse of any evidence-based treatment for adolescents. And the focus, and parents are often confused because the focus is broken into 3 phases, which I love because there's a beginning, middle, and an end. And the focus is really just getting the food in. Like, there's no
right.
talk about your feelings. There's no let's hear what's going on with you. I mean, again, there might be minimal bits along the way, but the primary focus is we've just got to get the food in, because the philosophy behind this is they're pre-treatment. You can't do therapy with an eating
Right.
disorder. You can
They're
do
not
therapy
thinking
with a
clearly.
person.
Right. They can't think clearly. But the question I have
Exactly.
here is, you mentioned OCD, and I do believe that OCD is often goes along with, as a separate disorder.
Hmm.
I'm wondering if someone who already has OCD is more at risk and that the malnutrition state would exacerbate the
You've
OCD.
got it 100%. a
Hmm.
100%. If someone has OCD already to begin with, and then it starts to, like, as will what is normal with OCD oftentimes is it kind of morphs.
Hmm.
It may start with one thing and then it can kind of like evolve or attach itself onto something else. So, someone who has OCD can very easily be triggered into an eating disorder, and you need to be super careful with that. You need to be super careful with that, because exactly what you said, if it starts getting into the food, that's why also, let's say, um, that's why recommendations to the right people are so important, because I've
Hmm.
had cases before where, let's say, there was a girl with OCD and she wasn't eating well. Let's say either she was a little heavy or she started to lose weight, and mom gets nervous. So what does mom do? She says, okay, go to a nutritionist. So she sends her to a nutritionist who has no experience in eating disorders or any background in mental health. And
Oh
the
no.
nutritionist starts to, exactly, you're saying, oh no, already, has got her weighing her food and
No.
measuring her food
I'm telling her
and
which foods are
thinking
good
about,
foods and bad foods. No.
exactly, exactly.
Oh,
So that's why it's so important that you go to the right people, and that if you know my child has this sort of predisposition already, that you are very careful, because that does make them more at risk. And then when you've got a combination of severe OCD and then malnutrition, it definitely can evolve into an eating disorder, and that's often the harder cases.
right. I mean, I kind of think of it as grooves in the brain that just keep digging deeper and
Right,
deeper
right.
and deeper.
Definitely.
And parallel to
Definitely.
that would be anxiety. I'm pretty sure that anxiety is often highly associated.
Right. Yeah, a hundred
And it's the
percent.
same, the
A
same
hundred
kind
percent.
of thing. All
Look,
those common.
anything, I always say, like, I could have 5 girls. The reason why also eating disorders are so complex to treat sometimes is because I can have 5 girls standing in front of me and they all have the exact same symptoms of the eating disorder, right? They all have
Hmm.
the exact same symptoms, but each one is coming from a different place. One of them could have the anxiety, the other one could have the OCD. One of them, God forbid, could have been sexually
Right.
abused. Another one, let's say there's a lot of stress in their life, the parents got divorced, or very low self-esteem. There has to be a fertile ground that gets triggered into the eating disorder. So the more fertile your ground is, the more easier you are going to be triggered. And unfortunately, we live in a society where
Hmm.
being thin is the ideal, unfortunately, however much we try and protect ourselves. So there are going to be those triggers everywhere you turn.
Right.
So
And
it's
from a
definitely
preventative,
something you have to be.
right. And from a preventative standpoint, first of all, this is something that I really focus on a lot. If people listen to my podcast, you can scroll back and see how many we've done on body image, on how to raise
Hmm.
girls with a healthy, self-esteem and body image,
Hmm.
on intuitive eating, which I don't know if you want to get to or not. I mean, it's so, so important from a preventative standpoint. There is so much we can do.
Right,
But you
right.
can't
And
control
so,
everything. So when you say prevention, of course, I want to be careful because you cannot control everything that happens to your child. Only Hashem's in control, right? You
right,
can't control whether something's going to happen to them or certain triggers, and you can't control whether they have OCD or anxiety tendencies. You can't
right,
control family stress. So there's some, and there are genetic predispositions, right? So
right, right.
I did a talk actually with a physician who was able to share her story. It's an amazing episode, and we talked about some of these factors are preventable, and some are not. And the interaction of, you can only do what you can do. But I'm giving you a segue to talk about what you can do for
Right.
prevention.
Right. No, for sure. So just the only other thing that we just skipped though, because
Oh,
I mean, like I've got so much to say, and
I know.
I don't want to lose out on this, and I appreciate the opportunity. The last real, as far as the eating disorders though, and as far as the types, what is important to know is that sometimes, someone can have an eating disorder and it doesn't fit exactly
Right.
into the diagnostic criteria, and I don't want someone to say, well, she's doing this, but she's not doing that, so it must be she's okay.
Hmm.
There is something called OSFED, otherwise specified feeding and eating disorder, or it used to be, called EDNOS, eating disorder not otherwise specified. And then they can say, well, you've got anorexia with a bulimia subtype. Whatever the case is, it doesn't have to fit exactly into the box, but those are the main ones. The other one, I think you coined the term, the new eating disorder on the block would be
Right.
ARFID.
Hmm.
ARFID is ARFID, are the letters it stands for, and it stands for Avoidant Restrictive Food Intake Disorder.
Hmm.
And that's really, different, definitely very different, but that's more, I call it like picky eating on steroids. Most of the time, these cases, and we're definitely getting a lot of them lately,
Hmm.
I get them when the kids are very little. We're talking like 8 or 9 years old, 10 years old is pretty much the average. And these are the kids that were picky eaters since they were born. And the pediatrician said, oh, just give them more time. They'll grow out of it. They'll grow out of it. And then by the time they're 8 or 9, they haven't grown out of it. And the parents are just exhausted because it's not just, I'll only eat pizza. It's, I'll only eat this frozen pizza from this company. And you put it in the toaster. And if it gets a little black on it, I'm not touching it. So the parents are just exhausted because they're the ones that are trying so hard to cook the schnitzel just right, to get the exact brand of the food that they want. I had one case where the family couldn't eat anything fleshig because the little boy just couldn't handle the smell. He actually had to sit there with a jar of besamim, of spices
Wow.
to have, because he just couldn't handle the smell. So it's really the picky eating that's gone to the extreme. And we'll have two different kinds of kids. The most concerning ones are the ones that just are not growing.
Hmm.
Really, they're just not gaining enough weight. They're always hungry. They're always cranky. And they're just not reaching their milestones on their growth curve. And I will have also sometimes, which is an interesting one, I have the opposite, in that the kids who are very heavy, I've had kids with ARFID who are very heavy because the only foods that are their safe foods are the foods that are high in calorie and very low in nutritional value. The only thing they will eat is pasta
Hmm.
and bagels and and snack bags,
Right. I have to
because
chime in
that's
here
the
for a
only
minute.
thing.
Right. I have to chime in as a pediatrician for just a minute.
Please.
So one subgroup of this ARFID class is kids with ADHD or even on the autism spectrum. And some of them are so picky, I've seen them get scurvy. So you're
Oh
right that their weight
goodness.
can be completely normal, but they may be eating only three foods.
Right.
So they do fit
Right.
into that
Right.
category if they're eating so few
Hmm.
foods that they're not able to get proper nutrition.
Right.
Um, Another thing you mentioned was sensory issues. So you may not be on the spectrum, they may not have ADHD, but the sensory issues is often a common association.
Right. Now the challenge with RFID is, um, these are also kids who are probably going to be a little bit more rigid. They have a harder time transitioning,
Hmm.
um, from one activity to the other. They are a little bit more rigid with specific things. The challenge with RFID is it's a newer diagnosis. So anything that's a newer diagnosis, it is also going to be newer for to be treated. So there aren't going to be a lot of people out there that are successfully
Right.
doing RFID. FBT, which is what I mentioned before for anorexia in adolescents, has shown some success, but there's a great new treatment now coming out of Duke University. There's a wonderful psychologist there by the name of Dr. Nancy Zucker, and it's called, she's named it FBI. I know she's actually been writing a book. FBI stands for Food and Body Investigators, and it's
Cool.
a super user-friendly treatment for parents and kids both together. It's making them again aware of when they're hungry, making them aware of, a lot of the kids will complain about stomach aches. So that's why it's Food and Body Investigators, that there
Hmm.
aren't bad foods. It's just like, interesting foods. What would that be like to try it? It's much more complex than how I'm describing it. But
Interesting.
that's, I was just privileged enough to pop into one or two Zoom trainings that they were having now for this.
Wow.
So ARFID is treatable, but it is newer, the diagnosis, so it is sometimes harder to find someone who really knows what they're doing. So that is the challenge. But those are, and again, those are coming out when they're really 8 or 9 is often where I get it, and surprisingly, it's more with boys than with girls. It's a little bit more common with boys than with girls, and the main difference between because sometimes I'll have parents who think, okay, my kid has anorexia, and the main difference is that this is not a child who doesn't want to eat because they don't want to be fat. This is a child who wants to eat, just doesn't have the foods that they like, or doesn't have enough of them. But it has nothing to do with a fear of fat. It has nothing to do with their body image, with being slim or looking a certain way. It's really just the foods themselves they can't tolerate and they just don't like. So that's the challenge there.
Right. I want to add just in a few other little
Sure,
typical
please.
scenarios, because I'm seeing this. I'm seeing more of this than I'm seeing the classic eating disorders right now. Don't know why. So one subcategory is a child who's had a bad experience. They may have choked on something.
Yes. So that, I don't know if that would be a subcategory of ARFID or that, because sometimes we treat that almost like a trauma. I've had people who, again, if they've choked on something, again, it becomes like a phobia. They've choked on something. These are the ones when I get the little guys, right? And the parents think maybe it's anorexia, and it's not. That's such a great example that you gave. These are the ones that they choked on something and now they're nervous, or they saw someone throw up. And now they've got this phobia. Well, I don't want to throw up, so
Right.
I can't eat. So it's really treated like a phobia with cognitive behavioral therapy and exposure response prevention. It's treated a little bit like an OCD or like a phobia. The main thing is, though, you want to get it right away, because the more malnourished they become,
Right.
then it gets more complicated.
Right. I mean, I think that's how you divide it between a phobia is when the child is already restricting calories. They're restricting calories not because they think they're overweight, but because they're afraid of vomiting in public.
Of
For example,
something
I had
happened,
one,
right?
or they were afraid because they choked in the past, or they're
Exactly.
afraid of you being, disgusted by the sensation of it. All of these things fall into the same category of it's more than just a phobia if you are already restricting calories to the point of being underweight.
Right. But the thing is, though, again, with the ARFID is typically like since they were little. What you're describing with the choking, with the vomiting, that would have been a kid who was eating fine, and then something happened.
Right. So there's different subcategories. I actually just finished an insert, a CME article on this, and they had all these categories. And I think the definition is not by how long standing it is. And I think, it's a new diagnosis. This came out in 2013. So I think maybe when you start out with a new diagnosis, you look at the most classic cases, and then you realize it's a spectrum and there's different presentations. And so I think that these are all patients that I've seen varieties of that I think do still fit into the ARFID category.
Right. Okay.
But I think that the point that you're making of how long lasting it is, it's still the same point. Prevention partly is just catching it early enough. It'll be so much easier to treat.
Right.
I think one of the problems of the children who have been thin forever,
right,
is that it's been going on forever.
Right.
You can't correct that malnourishment as quickly as you can a more acute, quicker onset of weight loss.
Right. No, definitely. Definitely. So that is a big challenge.
I'm wondering whether you're seeing a rise during the pandemic like I feel like I am.
So that 100%, I mean, it was interesting because, when the pandemic hit, just even socially, like all of my colleagues agreed, people would say to us, oh, you must be so busy. You must be so busy. And we were like laughing amongst ourselves because like the phones weren't ringing in the beginning, because I think everyone was just so shocked and so overwhelmed and just trying to survive and get through the day, that nobody was like, okay, I need to go get a therapist now. You either had your current therapist if you were in the middle of an issue, or if there was an issue that came up, you just couldn't handle it. It was like, I say, make a joke. It's like the same thing with going to the dentist or certain routine medical things. Like nothing happened. Like nobody was going to the dentist then. Like if you had a cavity, you just managed.
We all
unless unless there was something that was truly urgent. And then afterwards, it was like everybody was sort of just like digging themselves after the big crunch in the beginning. They were just sort of like digging themselves out of their holes and figuring out, okay, what needs to be fixed here? Like, okay, which one of my kids needs a tutor? Which one needs to go to the dentist? Which one needs this? What do we have to do for therapy? So then the numbers started coming up again and people started calling. And then we had people who were like, okay, now we need to get resources. And then it was also finding the resources, because therapists, I found out, and doctors, they're people too,
Surprisingly,
so, yeah, exactly. So they also had kids at home. They also had to cut their hours. They also had limited availability. They were also navigating doing this via Zoom
Right.
when they
They
had
didn't want,
never done it, when
right.
when they
Didn't
had
want to be
never
in
done it
person.
before.
Right. A lot of people
So
are doing tele, and some people upset. They
exactly.
want therapy in person. I'm sorry, it's a risk to the therapist.
Right, right. So, you know what I'm
Mhm.
saying? So that was, sort of figuring that out. And then I feel like now that's where we're up to. Then is where the crash happened. I find there were so many people that were
Right.
doing well
Hmm.
before, and then either parents sent them to camp. They had the opportunity to send them to camp. They just sent them because they'd been cooped up in the house for so long, and the camp opened, and they just sent them, even though they knew it wasn't the best thing. Or kids who really, the parents thought they were doing well, but now that they were home, they said, "Oh my gosh, they're really not eating."
Hmm.
Or the kids that being with all the family members and the stress and the difficulty, or parents being with the family members and the stress and the difficulty, just really triggered a big regression.
Right. I mean,
So definitely.
what I'm seeing though is that in the beginning, I think, when you're in an emergency, you pull together.
Hmm.
And I don't think it's so much later you're digging out that may be a part of it, but I think also that once we came out, everybody did different things. Some people were careful, some people were not. Some people wore masks, some people did not.
Right, right,
And I think that that uncertainty was much more difficult, and I think led to a lot more anxiety. Plus the spread of COVID once we came out and it started, the second wave
right,
came.
right, right.
And we're
No,
tired, and we're so tired, right?
yeah, no, look, definitely. And I think it is, when it's hard to connect to resources, you kind of push off trying to find the resources.
Hmm.
And there were a lot of people, people ask me, does therapy on Zoom really help? And I tell them, look, it's not, I only say it in Hebrew, I don't know the English equivalent. It's not lechatchila,
Right,
it's not, our best case scenario, but we're not living in a best case scenario
right,
world. We're living in a
right,
b'diavad world.
right. Don't let perfect be the enemy of as good as you're going to get.
Exactly, exactly. So I think that was a lot of it. But then there, so I think across the board, I don't think we really. I mean, thank God we are resilient. People on a whole are resilient. I think Jews are resilient,
Hmm.
but we've really gone through a tremendous amount, and it's not over yet.
Right.
So it's definitely been much, much more difficult now. So there are people, a lot of people I think who are doing well that were just really triggered and fell apart. I don't know if I had so many brand new cases. I mean, definitely July was a very busy month. I had a lot of kids who were finally going to the pediatrician
Hmm.
that hadn't gone, right. It's always right before camp. And I talk about eating disorders a lot with adolescents, but it really, I get a lot of adults also, but I think the the adolescents, they make a little more noise in my mind, and I think there's more, in some ways, more that we could do aggressively and proactively, than someone who's unfortunately had an eating disorder for a long time. But a lot of, I always get, like, right before the summer, especially when you had some camps opening, some camps not opening, that's when I get a lot more cases, because it's like, oh my gosh, we just took her to the pediatrician for a well visit, and she
Right.
lost 17, 18 pounds from last year, and she grew 2 inches.
Right. You won't know unless you go and get weighed. So, can
Exactly, exactly, exactly.
we talk about prevention now?
Yes, please. I love
Thank you.
prevention. I love prevention. You know, eating disorders, I feel, more than any other mental health issue, has the greatest room for prevention. You can't prevent OCD. You can't prevent depression. You can't prevent you can't prevent bipolar disorder. You can try and make those things more manageable. You can try and be more prepared, but you really can't prevent it. And eating disorders, I definitely think it's very different. What I've been able to do, and what I've seen in the past, through my opportunities that I had at Relief, and in being connecting with some of the top clinicians out there, I was able to connect with someone by the name of Dr. Catherine Loeb. So Catherine, if she ever hears this, she's gonna laugh, but she's like my Rav, my Rebbitzin, my Rosh
Oh,
Hashiva, my professor, and she's phenomenal. She's just phenomenal, and she's really an expert in the field of eating disorders and adolescents and women's mental health. And I had the opportunity to be in touch with her, and she, at that point, she was working at Fairleigh Dickinson University, and one of her doctoral students wanted to do her dissertation on a prevention program. She took an eating disorder prevention program from the secular community. It was called the Body Project. And what she did was that she said, okay, I want to make a cultural adaptation for the Orthodox Jewish community.
wow.
And she asked me to come on board to be the cultural consultant, if you will, with trying to make it as culturally as appropriate as we can. So the theory behind prevention with eating disorders in general is it is tricky, because you know, there's a fine line between, you know, making triggering comments and actual prevention. So, you know, people have talked about in the past, okay, well, let's have someone go to the schools and tell the kids eating disorders are bad, you know, and that has there's nothing at all to support that. Unfortunately, if anything, there's been a lot of data to show that that's ineffective, because what that can often do is be very triggering. Eating disorders do have a little bit of a contagion factor, and that's why you have to be very careful with what you're reading, what you're letting your kids read, you know, and that it's not something that's describing a lot of symptoms and behaviors. So once we found out, okay, you know, if we talk to kids about eating disorders, that's not going to be helpful. So what do we do? So what this program has been so helpful is that the Body Project works on it works on combating the thin ideal. The philosophy behind this is, if, you know, I don't want to say everything starts with a diet, okay, but we talked about having that fertile ground, right, before. So if we can stop that fertile ground from being triggered into an eating disorder, that's where the prevention is. So how do we prevent it from being triggered into the eating disorder? If we can work on body dissatisfaction, if we can work on thin ideal internalization, if we can work on those things, then that can stop us from getting into that I want to be skinny and starting with those negative behaviors. So what the Body Project really does is based on the foundation of cognitive dissonance. It works on combating the thin ideal. It has you say right, and you know, say right and think different activities that go against this thin ideal internalization. So it really works on, you know, I mean, you know, for lack of a better way of describing it, on convincing you, or helping you convince yourself, being skinny is really not good. And we're being, not only that, but we're really being tricked, if you will, by the media. And it goes through that. So we did this, we had this opportunity to do this adaptation. And we actually did a pilot study, and we ran this. It's a 4-session intervention. It's a workshop with students where it doesn't discuss eating disorders per se. It talks about, again, this thin ideal, and what is the thin ideal, and where does it come from, and is it really something that's attainable, and what are the negative effects of trying to attain this unattainable goal. And it gets them motivated, and it really, in many ways, gets them fired up into, you know, into working against it, and stopping themselves from promoting it, because there's so many ways that we promote the thin ideal without even recognizing it. So, you know, that's very much been a very strong focus, and it's a program that, you know, I don't know if this is where you wanted to go and talking about, you know, prevention, and I don't want to be, you know, standing on a soapbox here, right. You know, just pushing one method, but that's really been very, very effective at combating the thin ideal and really preventing eating disorders, and the data proves it, and that's what's fantastic, because I love data, I love science, I love data, and it just shows that it prevents eating disorders. It also prevents obesity, and I'm talking about the main, you know, the Body Project in its purest form. We also had similar results from the time that we did it, but the Body Project in its purest form, it prevents eating disorders, it prevents obesity, and it improves negative affect, which, again, you know, how we feel about ourselves is so intertwined with how we look, unfortunately.
Right. Now, is this project available to students now?
Yeah. So, so again, I don't want this to be an infomercial or an advertisement, but you know, we do what we have done is we did our pilot study, which we got great results, which we were thrilled with. And now we're just trying, and again, it's in my spare time because this is something extra I'm doing. We're trying to get this out to more schools. So we've actually, I don't say we renamed it, but in trying to make it as culturally appropriate as possible, there are some communities that don't like saying body. So calling it the Body Project, you know, we felt was going to be an issue. So we've actually renamed it Project Everybody.
Okay.
And we actually have a website now with information about it, and we've already given it out to a couple schools. I do the training. It's based on a train the trainers model, where I come in and I give it's a 4-hour in-service to the teachers or the staff, whoever is going to be giving it over to the students, because it's really most effective when it comes from someone in the school. And then they they then take it and they give it over to their students, and we've already done it in a couple high schools, and they just love it. So
Which
it's
school?
fabulous.
I'm just curious. Which
So
school?
sure, in Toronto, of course I've forgotten the exact
Oh,
name.
wait, in Toronto, but how about in New York?
No, for sure. We did it in Beis Chaim Mushka in Crown Heights.
Okay.
And there's a couple other schools that are also interested. But again, it's something that we're doing in our spare time. It's not a moneymaker. You know,
Right.
we have we have some supporters who are, I mean, I think there's value. There has to be a price on everything for there to be a value to it. So I would love to just give this free to everybody. But we do have supporters that are subsidizing our costs so that no school would ever not be able to do it because of the cost.
That's amazing. What is the website?
So it is Our Project Everybody.
OurProjectEverybody.com.
Very new. Yeah, it's very new. So I just want to make sure that I'm saying it. We're very excited that it's up and running.
I'm checking this out.
Yeah, please do.
But yeah, I do have
it's OurProjectEverybody.com.
Okay, perfect.
And the fabulous thing was, again, this is another thing, about relief, because we do have connections to such great people out there. When we did the adaptation, I did it together with Dr. Rillo, but we did it with the originators of the first body project. We did it with Dr. Eric Stice as well, and he was very involved. So, it's something that we put a lot of time and effort into. But the main thing is, and this is where I think it's good for your listeners to know, aside from this, let's say they don't have high school students. Let's say they don't have kids in high school. Let's say they're not looking for something like this. There is so much that we can do, and this is something that you learn in doing, doing the body project and doing these little workshops. There's so many things that we say that we don't realize are really perpetuating this thin ideal without our even noticing it. I once saw an advertisement for an eating disorder program or whatever it was, and it had a mom standing in front of a mirror, and she was kind of checking out her hips and how she looked, and just a very dissatisfied grimace on her face, and her little girl was sitting in the corner behind her watching. And there's so much that we don't realize. We say, oh, I shouldn't have eaten that cake, I can't believe I ate it, or oh, I need to lose weight before the wedding. And even when we meet people, oh my gosh, you look so good, did you lose weight?
Right.
There's so much we don't realize how the thin ideal how it's sort of crept into every aspect of our lives. I mean, if you look at even the most religious magazines now, out there, there's always going to be some mention of a diet, some nutritionist advertising, some low calorie new frozen yogurt. Dieting has become so much of our culture, and there's nothing Jewish about it. You know what I'm saying? It's nothing. And I think that's one of the main things that people learn from our program. And I think people need to know in general, even, aside from our prevention program, is that, you talk about these kids with the OCD, you talk about these kids who are anxious, these kids with that little bit of a fertilized ground, right? And the parents have to realize that they need to be more aware of what they're saying and what they're doing around these kids, that there are things that they can do. In my house, there's no bad foods and good foods, right? If you want a bag of chips, you can have a bag of chips, but take it with an apple and a cup of milk, maybe. I mean, I know that's an interesting combination, but just take something balanced, because if you're really feeling hungry right now, that's probably not going to fill you up. It's not like, oh, that's too many calories, or that's too fattening, or you're going to get fat. And I think even parents don't realize, and this is a pediatrician, this is your job, which I'm sure you're telling them, they don't realize. They get very nervous. I get a lot of parents who, the kid became 12, 13, before puberty, that started to get hungrier because their bodies were growing, started to make some, start going to the pantry a little more, going to the fridge a little more. Parents start getting nervous. They start making comments. Don't eat that. Don't eat that. Don't eat that.
Right. We have a whole separate talk on obesity in a non-shaming way, a whole separate talk, which, by the way, the endocrinologist I did it with, we obsessed over for a full week before doing, because it's such a sensitive topic. Even how we talked about it, we wanted to be sensitive.
Right.
And I also want to say that there was actually a column in the Jewish papers. And it was actually Rabbi Yitzi Ross, who's actually a Rebbe in South Shore where my boys went. And the question he had was, of a mother of a 9-year-old, my child's eating too much, he's gaining too much weight, I'm worried about shidduchim.
Right.
9. We hadn't mentioned shidduchim yet. This kid is 9.
Right. So that's really, again, the main premise behind the thin ideal is really, where is it coming from? right? Where is this coming from? And in truth, it's really coming from the media. And this is a longer discussion than for the
Right.
time we have left. But it's really coming from the media. Every advertisement that you see is there to make you feel that there's something wrong with you. And if you buy their product, it will make it better. Whether it's making your complexion more perfect, whether it's making you happier, whether it's all of these things. And now with Instagram, with social media, with all of these things, and you see these perfect families, and you're just bombarded with images, right? All these images of what people should look like, right? The average, I don't have it right in front of me, but I think it was something like the average American woman is like 5'4" and 100 and let's say 65 pounds or something, right? And the average model that's modeling for this American woman is like 5'10" and
And 100,
115.
right. But this is
You know,
true for the most frum communities too, though, that it's seen
exactly,
everywhere. I
exactly.
don't care whether you have a smartphone or a stupid phone,
No, a
right?
hundred percent,
Whether you use
a
the
hundred
internet or not,
percent.
it's in there. It's in our shidduch worlds where we put
I
pictures
even
of
once when
women
we,
on
we were
there.
doing the research for this project, I actually reached out
Mhm.
to, because we were talking about this. We're like, okay, there are those who say, there are those who have complete access to internet that in the community. Then there are those who have limited, right? And they're doing a lot of shopping. I laugh. Zara, like whoever shops on Zara, I feel like they get their models straight from the eating disorder units. Like they get
Oh,
discharged, and Zara is the worst. So they're seeing these images, those that have minimal internet use, because a lot of them are shopping online now. Online is very common, even if you have limited. But then there are those. So let's say there are those we were looking at, and we're like, okay, what about those that don't? That just don't. So first of all, any billboards, any advertisements, you go to the mall, the outfits are pinned. The mannequins couldn't menstruate if they were people,
right.
right? So they're showing you these images, even
Distorted.
when you're going. And then, but not only that, I actually interviewed. I went to one of the Frum clothing stores, and I asked them if they could give me, some of the contact names and numbers of their Orthodox Jewish clothing manufacturers. Like I wanted to hear from them. And I remember interviewing this one woman, and she was saying that it was a big challenge for her because everyone was requesting slimmer cuts.
Mhm.
Everyone was requesting, even on pajamas. And she said, like, she struggled with it as a frum woman in doing what she felt was right, but also in making the customers happy. So here she is, a Orthodox clothing manufacturer, right? No internet, nothing. Orthodox clothing manufacturer. You go into your frum store, and she said everybody wants thinner, thinner cuts. And I even, like, my one of my children, like, she knows already. We go to the store, and I'm like, we don't look at sizes. We don't look at sizes. The sizes, I tell her, these sizes are so crazy. These sizes don't make
They differ
sense.
for different manufacturers. You get what looks
Exactly.
good on you.
Right. But
Different
everyone's like, I want
bodies
to
have
be a
different
size zero.
shapes.
I want to be a size zero. I want to be a size zero. So
I,
we don't want to be any size,
Yeah, I'm
But
putting a plug for two things here. One is intuitive
please,
eating. One is intuitive eating, which we didn't get to, and just people can listen to the talk on that. And again, this is not medical advice. Everybody's different. This is not a treatment for eating disorders, but intuitive eating sort of teaches you to get the opposite of the diet culture, to learn how to eat with pleasure and moderation, right?
and I think that's
Um,
great. Not for patients that have had an eating disorder, but definitely for those that are just struggling with a lot of disordered eating or just feelings of
Disordered eating,
unhappiness
right?
with their relationship with food. 100%. Yeah, intuitive
Or
eating is great.
past the recovery stage, because
Hmm.
it can be helpful um, for people with a prior history of eating disorder, but not it's not a treatment. And the other point that I wanted to make was, I actually forgot. Oh gosh.
I'm
So
sorry, I
intuitive eating.
interrupted
Oh,
you.
health at any size. So health at every size. I'm gonna get some people are gonna be mad at me for talking about this and plugging it a little bit, but I just want to plug the basic concept. There are some people who do take it to a more of an extreme, that there's no such thing as obesity. But I think that the basic concept of different bodies have different sizes that they're healthy at, and it's the opposite of the thin culture. You
Right,
need to have healthy habits more than a specific weight or a specific size.
right.
So I think that that's very valuable, and there's a lot of therapists and nutritionists that do follow that, and that will not, be triggerers for
Yes,
eating
yes, no,
disorders.
100%.
Because say if you have
100%.
a child, I do see this all the time, kids who are gaining weight in puberty, and they really do need to learn how to eat healthy, but we don't want them to have the kind of nutritionist that's going to have them weighing their food and counting the
Right,
calories and plating it out. So you may want to keep your eye open for a health at every size, with the caveat
right,
from me saying, as a physician, it is not true that you cannot be unhealthy at unhealthy. Well, there are unhealthy weights, and we're not talking about that. And one more
right.
thing I want to say, is that Rabbi Rusk gave a great point. He said we should be teaching the boys not to look for sizes. Why are the shadchan saying, I have a great girl for you, she's a size 0?
So I think, and this is also coming as a mother, because I have two sons in shidduchim now also,
Mhm.
I think I see it more as everyone wants the beautiful girl.
Mhm.
Everyone wants the beautiful girl. I think our vision of beauty is what has changed.
Right.
And I know myself, and I've and for looking for girls for my own boys, I don't need that size zero. I don't want that size zero. And I'm happier to take someone who's fuller figured. I would have no problem with that. But then I want to know, what's her relationship with her body? Is she
Right.
miserable? Is she miserable? Is she always on diets? Is she busy with it? But I think it's our vision of beauty has changed. We always wanted the beautiful girl,
Mhm.
right? And always in shidduchim. It's just our vision of beauty has changed, and that goes back to, what are we being told is beautiful, and
Right.
what are we being shown is beautiful. And that's the thing. So I think not focusing on don't want the size zero, but focusing on, well, what's really important, having that conversation with your boys. What is really important to you? And what do you think, and why is that? And where is that coming from? I think that's definitely something really important.
That is beautiful. And I want to thank you so much for your time. We could talk forever about this and we're
Yeah,
never going to be done. But I do want to
for
say that people
sure.
can listen to the other episodes of the podcast. There are, I don't know, maybe 5 or 6 or more of them to augment this one with an eating disorder, and some with an eating disorder, on weight issues, on healthy eating for children from the earliest ages. There's so many that we've done. So people can listen to those and augment this. And I want to thank you so much for doing this with me. You're so knowledgeable and this is so informative.
Please, please, this was a lot of fun. This is really a lot of fun, and I appreciate your time. And I've checked out some of your other podcasts, and I think they're all fantastic. And I've recognized some of the names of the people you interviewed, so I feel very honored that you included me with
Well,
that crowd.
I've been chasing you. I'm honored to have you.
All right,
Thank
great.
you
Thanks
so
so much.
much. Be well.
Take care.